Straight away, we are going to, into another presentation by ZHOU. Ethel is a radiographer, and she's going to take us through cervical length changes in nulliparous versus multiparous women in Zimbabwe, a cohort that she conducted in second and third trimester pregnant women. Over to you, Ethel.
All right, good morning. So I'm going to be presenting about the cervical changes, the cervical length changes that occur in the nulliparous women versus the multiparous women in a Zimbabwean cohort from the second to the third trimester. All right, so the cervical length were measured using the transvaginal ultrasound so that we were able to predict preterm birth. And preterm birth has been a problem, and globally it is approximately around 15 million babies born prematurely. That is making up roughly 11% of all the live births worldwide, and that is according to the World Health Organization 2021. So preterm birth has been a burden, especially in countries with low to medium to middle incomes, especially the sub-Saharan Africa. And in Zimbabwe, as we heard from the previous presenter, around 34%. So these were the objectives of my study. And these included to determine the cervical length changes that occur in the nulliparous women versus the multiparous women from the second to the third trimester. To assess the relationship between parity and cervical length in both the multiparous and nulliparous women in the second to third trimesters, and to determine the rate of cervical length shortening between the two groups of women, the nulliparous women and multiparous women, from the second to the third trimester. Okay, so this was a prospective cohort study at 2 hospitals in Harare. Most of my patients were from Salim Gabe and just a few from Parirenyatwa. And this included 130 nulliparous women and 94 multiparous women. So the cervical length was measured using the transvaginal ultrasound, and my data was collected from 20 to 22 weeks. That was for the second trimester, and the third trimester from 28 to 30 weeks. Analysis of data was done using the SPSS and independent samples t-tests. So the inclusion criteria included the nulliparous women and multiparous women who had singleton pregnancies at 20 to 22 weeks and 28 to 30 weeks. And this included those who were just receiving their antenatal care either at Parirenyatwa and Salim Gabe, but I found most of my patients at Salim Gabe Hospital. And this excluded the women who had any history of cervical surgery, any cyclages, and any other pregnancy abnormalities. And for the multiparous women, they were not supposed to be having a history of preterm birth. So for my results, the nulliparous women, that is for the 20 to 22 weeks, their mean cervical length was around, it was 39.55 millimeters. And for the multiparous women, it was 37.69 millimeters. For the third trimester, from 28 to 30 weeks, it was 36.24 millimeters for the multiparous swimming and 35.11 millimeters for the multiparous in the third trimester. And this gave the P values of 0.0006 for the second trimester, which was statistically significant, and 0.0039 for the third trimester, which was statistically significant as well for the cervical length differences. And then for the cervical length rate of shortening, the nulliparous women, they had a faster cervical length rate of shortening, which was roughly around 0.41 millimeters per week. And the multiparous women, they had a cervical length, the rate was 0.29 millimeters per week. And the p-value was 0.022, which was statistically significant as well. So this means that parity significantly influences the cervical length dynamics, because in the results it was clearly shown that the nulliparous women had longer cervical lengths, but they had a faster rate of shortening compared to the multiparous women. And the clinical implication was that their risk profiles, they differ. So in conclusion, parity must be considered when we are screening for preterm birth, because the nulliparous women and multiparous women, they follow different cervical length trajectories. And there is need for parity-specific reference ranges in Zimbabwe so that we cater parity. And for the recommendations, there is need for local cervical reference values that will be stratified by parity, and a larger scale research must be done at multi-center studies, at multi-center hospitals in Zimbabwe, so that I think we get more results where we can compare with this research. And after that, maybe we can incorporate the findings into antenatal screening protocols so that preterm birth is improved and it's reduced in Zimbabwe. Thank you.
Okay, thank you very much, Ethel. You can come. I'll ask the presenters to come and take the beautiful seat, as they will be responding. We are getting into discussion. So any questions for the presenters? Any questions?
Thank you. I'm sorry, I forgot the last speaker. So I just wanted to say, probably from what I know, I might be wrong. Parity only does not conclude the issue of cervical length. There are several factors to consider, like the maternal age, the maternal weight, even the gestational age of the pregnancy. So I'm not so sure, did you consider that when you were doing your study on it?
No, I didn't consider.
Dr. Regan.
Thank you. I'll ask both of you. First of all, I want to say Thank you for choosing to research in fetal medicine. But I want to just highlight the issues to do with methodology when you are doing studies. That there has to be methodological clarity. As long as the methodology is not clear, the results don't matter really. So when you are presenting your results, your study, try to be clear with what you did exactly, so that we can believe the results. Because if the methodology is not clear, even no matter how nice the results look, we'll not be able to believe them. What do I mean? When you are presenting a study such as this one, which is the cohort perspective, there is a procedure which is being done. First of all, we want to know, was the procedure being done according to standard by who was doing that procedure of cervical length assessment? Where were you recruiting your clients from? The ladies you saw at 32 weeks, are they the same ladies you saw at 22? 22, right? At 28 to 32 weeks, are they the same ladies you saw at the 22 weeks? We want to know that kind of information. What was the loss to follow-up of this cohort you started with? It is impossible to have 100% adherence in Zimbabwe, even in other countries. So the methodological clarity has to come out nicely. The question that Tino asked is emanating from lack of demographic data and also a comparison table of the women's characteristics to say these women in the two groups, were they comparable at all, or were dealing with probably different kind of women? So in other words, matching your two groups is very important if you want to make a reasonable comparison. So methodological clarity probably is a big issue here, which probably needs to be addressed so that the results can be believable, to say, look, these results mean something. Then when you are saying we should treat them differently, we know that cervical length, as long as it is above 25 millimeters, doesn't matter where it is. We only get concerned if the cervix measures less than 25 millimeters in mid-gestation. If we pick up a cervix which is 15 millimeters and the woman is having no complaints at 36 weeks, we are not bothered. So for us to make this kind of conclusions, to say we now need a new nomogram, if we had assessed the risk group and it proved to us that there's accelerated shortening below the cutoff of 25 millimeters, because it's natural that all cervixes have to shorten. It's something that is known in obstetrics, that a nulliparous versus a multiparous, a nulliparous is going to have a shorter cervix compared to a multiparous is going to have a shorter cervix compared to a nulliparous women. Because it is only the cervix length which is greater than 25, less than 25 millimeters that matters if you pick it up in mid-gestation. So I'm just saying this so that you can work out on your other sections of interpretation of this result to say how should these results be interpreted properly so that we don't misinterpret them. Then to Barbara, I always want you to show us the stitch failure rate, which you didn't mention, because people should not think that this is a silver bullet. The stitch fell in about 10 to 14, but yesterday, Mr. Kumbula told us that 20-something% of the bigger cohort they followed up, the stitch failed. So whenever a study of preterm surveillance is done, we want to know what was the stitch failure rate. We also want to know what that adherence which you complained about was. What was the adherence rate to that progesterone in your group? Because most of your subjects, they were taking the two methods, both the progesterone and the cervix. They were on the cervix. So we may be interested in knowing, say, okay, so what was the adherence? Since you said the adherence was so bad, so that we could look, how does the adherence compare to others? We have done similar studies. What is acceptable adherence of progesterone for us to say, look, let's analyze this data or let's not analyze it because it will give us biased results. So those are the questions I wanted to pose to you. But otherwise, thank you for the job. Then the psychology, so that I don't take the mic again. For the psychology, thank you very much, Evado. I was saying you guys reduced my nightmares when you came into the unit, because the nightmare came from especially the feticides, the TOPs. I would always ask myself, have we done enough in terms of counseling this couple to make an informed decision to accept a termination of pregnancy? Because it's not an easy feat, right? For somebody to carry pregnancy, we see them very late. We may see them at 35 weeks. Even at 40 weeks, we see them, and they may choose to just have a feticide. So when you started, my nightmares are better. I know there's now a second layer of counseling, but my question to you is, what is your experience with the health workers so far in terms of your role? Are we appreciating you, or we are still stuck in silos where we think we are the masters and you guys have no role to play?
Thank you, Doc. I think I'll answer that two-pronged, because that's the response we've been getting. So with the greater healthcare team, our FMU reception has been amazing, and they're receptive, they're willing to learn. And if you recall the training that I said we did as South Africa at Mbuyane, initially, it was just an issue of what are we going to get, what allowances or what lunch are they serving. And at the end of the training, the feedback session was quite interesting, because they were the members of staff that were there were very open, and they said, when you called us, we were thinking, what's new? What would you want to tell us as psychologists or as counselors? Because we know how to counsel patients. But after having gone through the module and the stepped care model that we taught them, they then said, we actually did not know anything. So to those that we have trained, the response has been good. And I must say, Mbuyane has been amazing, because we work from IKMC straight through to the ANC clinic. And they've been very receptive. But now that we've been moved into Parinyatwa, the staff that do not know what we're doing, what we're there for, feel we're overstepping our territory. What we're doing, they can do as well. There's resistance. And then also the lack of clarity of purpose. Why are you here? We feel we can do what you're doing. Interestingly, we have also opened up to the members of staff. Our counseling has been extended to members of staff, and we've said it's free of charge as well, because you cannot pour from an empty cup. So when the members of staff come in for sessions, that's when they say, look, I didn't know I needed this. So this is what you are doing to the patient. So I think it's also important that the powers that be also adopt. It's a low-hanging fruit. Members of staff also need to be taken care of. Their mental health is also very essential for them to take care of the patient. So training cannot be overemphasized. It's very important. We all need to be trained to understand the benefits of psychological safety amongst healthcare workers and for the patient as well.
Okay, thank you very much.
Great. Thank you, Dr. Benga, for the question. So for our patients, for those who were prescribed progesterone, only 5% were able to take progesterone from when they were prescribed up to 34 to 36 weeks. So going into literature, the studies that I found, patients were taking progesterone continuous. But for our patients, some of them, they will take for 2 weeks, 4 weeks, depending on their financial capacity. Some will take this month, next month they don't have money. So only 5% they were adherent to taking progesterone consistently. Then in terms of cervical sacrilege failure rate, apologies for not putting it up, it was 13.7%, and it was comparable with those we found in literature.
Okay. Thank you. Ethel, do you want to respond, comment?
Maybe I just want to clarify about the certain things that Dr. mentioned. So the patients that I started seeing at 20 to 22 weeks are the same patients that I followed up at 28 to 32 weeks. And I think that's the reason why, the other reason why I highlighted in my recommendations that maybe another study with maybe more people can be done, because in the study there was patient attrition. I think it was around 80% patient attrition.
Okay, so you managed to achieve 100% adherence in terms of follow-up, no losses to follow up?
No, patient attrition, which was around, yes.
Okay. All right, we have some questions on our virtual audience. For Dr. Ashdore, there's a question: what dosage of progesterone were you using? And then in the preterm surveillance.
Okay, so we're using vaginal progesterone 200 micrograms, and patients usually they were stopping at 34, 36 weeks for those who could afford to go up with the progesterone. But the majority of the patients they were stopping abruptly during the gestation. So it was difficult for us to say this was the cutoff point.
Okay, Tino is a question.
Sorry, I just got interested in this. You say they stop progesterone at 36 weeks, did you?
They were stopping at 34 to 36 weeks.
Are you happy to tell me what's the purpose of progesterone?
So we're giving them is for those with history of prior pregnancy loss, trying to maintain the pregnancy and help with cervical incompetence.
Thank you very much. That's what I wanted to say. So I believe that progesterone should be given probably up to 12 weeks, 16 weeks at most, because we'll be trying to give luteal support, isn't it, to prevent pregnancy loss. So when this pregnancy grows, the placenta takes over. So I mean, get me right. I'm trying to think what will be the progesterone still doing in this patient.
I think from studies which has been done, it has been shown that in those patients with cervical shortening, supplementing them with progesterone helps to prevent preterm delivery, especially the very early and extremely preterm deliveries. So that was our main point in giving them progesterone and continuing it up to 34 weeks.
Yeah, maybe to just comment that, Tino, maybe this probably you didn't hear of this one because maybe it's slightly off the field practicing. But Roberto Romero that did a lot of work on progesterone together with Professor Kipros Nicolaides. And there's now, let me say, very strong evidence that progesterone works in women with a short cervix. Progesterone will not only work if the cervix is less than 10 millimeters, then you need to put a stitch. So there's strong evidence that for women who are identified to have a short cervix, they are not understanding. You prescribe progesterone, 200 micrograms to take it at night, all the way up to 34 weeks. The 34 weeks is an arbitrary marker. The reason why people use 34 in Europe, because the outcomes of babies that are born after 34 weeks in Europe is just as good as those born after 37 weeks. So people will say, why bother the woman to continue to put it, ask her to put progesterone when her baby is not viable enough if it comes out and will go home probably with very few morbidities to none. So yeah, so that's the role of progesterone we're discussing. We know progesterone is a role in reproduction medicine for luteal support, but we also use it for stabilization of the cervix.
All right, Dr. Question. This will be my last question in the interest of time.
Thank you very much. I want to make two contributions. The first one to the psychologist. I've been practicing as a GP for over 15 years, and I don't even know where to find a psychologist. There's a lot of ignorance among doctors. I don't know how we can change that. So I think the first sort of attempts to conscientize has to happen amongst the fraternity. And the second point is, as doctors or health workers, we're generally not allowed to share information with the publics because I think of advertising or whatever issues. As a result, our people, the only information they have is from herbalists and quacks and snake oil salesmen. So the first time they actually encounter knowledge is when they see us at the hospital. As such, we lose many to follow up. As such, they all present late. And these are low-cost initiatives that could actually impact outcomes. Is there a plan to educate the publics? When do you need to book? Preconception, what do you need to look at? Are women understand? And not being done by a single doctor who can be victimized like me, but being done by an institution like fetal medicine. Is there a plan for that? Thank you.
Thank you, Doc. When we had a chat last year, you said exactly the same thing to me. I'm still waiting for referrals, Doc. You now know where I am. I think that's an area that needs to be worked on. I think just off the cuff, we all need to understand that we work better as a team. Like the saying, many hands make light work. In the literal sense, it does make work lighter because as a doctor, you start somewhere and end somewhere. As a psychologist or as a counselor, as a therapist, I start somewhere and end somewhere. But for me to know where I'm starting and ending, we need to be collaborative in our approach. So I would highly recommend to the different doctors that are here in your different associations and societies, there are people like myself, there are organizations like Salt Africa, with whom I work with, who are ready to work both pro bono and obviously the paid services, because we do need to pay bills, but we are there to serve. I think if we can present the work that we do in the different societies, that would make your work lighter as medical practitioners as well.
Okay, I think for the second question, we're asking how we can educate the patients on when to book their pregnancy. So I think it has to be a national collaborative, but they can be advised using social media, which almost everyone nowadays is using, the village youth workers in those areas which are not accessible to social media, as well as the general practitioners, because they are the ones who meet the patients more, giving them information on that they have to book in the first trimester, and also encouraging them to have a preconception visit. I think if we start from there, we can get some.
Just to add to what you just said, Doc, I think it's also important for the different bodies to lobby or rally behind the importance of, maybe not to call it adverts, because I know it's just health practitioners. Well, health practitioners, I'll use that term loosely, that are not allowed to advertise. But like Dr. Mkono said, you've got church sects, you've got dubious healthcare workers who advertise daily, and people would rather go to them because they are perceivably more accessible. So I think it's to rally behind the authorities that be, to tell them that we're losing patients, we're losing lives by not speaking more of our services. I think those are very backward policies that need to be revisited so that the right services are put at the forefront.
Yeah, so thank you, Dr. Mkono for raising the issue of awareness. I want to admit that the health system in Zimbabwe is very behind. The MDPCZ, while it forbids advertising, but it doesn't forbid giving knowledge about the presence of services. We know that there's a very thin line between that and advertising, but we can take advantage of giving knowledge for people to bring awareness to the people using social media platforms. So as fetal medicine, we still lack a certain cadre. I'm not sure how that profession has changed over the time, but I think they used to be called health profession officers, right? We specific to the discipline, who's aware of the issues to help with the communication part of it. It's something we are working on, but I think the last few years, thanks to the Ministry of Health, our teams have been going to the agricultural show. I think for the past 3 editions, right? 3 to 4 editions. They've been exhibiting at the shows, the agricultural shows, like the one past, they were there, interacting with the public, bring awareness the service they can access in the public sector. So there is a lot to do, and we need other people who are not here to help us craft the right message to help disseminate the work. I'm not just speaking about fetal medicine, I'm just speaking generally in health. There's poor messaging so that people don't get the information.
All right, thank you.